Hello everyone, Dr. Sam here. Thanks for joining me for another episode of the GP Show. So today, first episode of 2019, we are very lucky to have Dr. David Johnson, brain and spinal neurosurgeon at St Andrews and City to Coast Neurosurgery, and founder, I believe, the Functional Movement Training Centre and the NeuroHab Back Pain Rehab Program, which is just a fantastic, innovative program when it comes to functional movement. It's something I think we desperately need more of. So thank you so much, David.
Thanks, Sam. Thanks very much for asking me to be part of your show. Looking forward to it.
So let's start with some basics. Let's start with defining functional movement, because I think that's going to be something that will be a little foreign to people.
So I think that's sort of a $1 million question. And I think that really links into understanding how to manage back pain, because one of the big problems associated with the increasing prevalence of back pain is that we don't really have a definition of what good movement is. And the word functional movement is used quite a lot in the rehab industry. And when you actually think about it, well, I've asked people what they ask I've asked other rehab specialists and physical therapists when they use the word functional. What do they mean? Does that mean that I can turn on a tap, or that I can close a window, or climb upstairs, or walk upstairs? But I think it really goes deeper than that in terms of rehabilitating someone who has chronic spine pain. And if you're trying to rehabilitate someone with chronic spine pain using a movement-focused approach, you've got to have a clear definition. So, like if I said to you, Sam, what's the definition of hitting a good golf ball? You would need to be able to write down step 1, step 2, step 3, step 4. And if you were able to then execute those steps from a biomechanical point of view over and over and over again, like Tiger Woods does or Greg Norman, you then become a pretty good golfer. And I think in our daily lives, we are participating in what I call the sport of life. Why can't we apply those same principles for grandma, hubby, wife, daughter, everybody, to make them be good at the sport of life? Because that's probably the most important sport of all. We're all participating in that, from when we get up in the morning at 7 a.m. to when we go to sleep at 10 p.m. or midnight. For 16 to 18 hours a day, we're participating in this activity that we should really consider to be a sport. And let's define what the points of performance are to be good at that sport, because then we can eliminate the biomechanical stresses that are part of that daily life activity. If we eliminate biomechanical stresses, we then eliminate biological inflammation. We eliminate biological inflammation, that starts to reduce pain and disability associated with our musculoskeletal system. And if you actually think, well, why do we have a musculoskeletal system? Why do we have muscles, joints, bones, ligaments, tendons? It's for movement. That's the primary role of having a musculoskeletal system. If you look at an animal that doesn't have a musculoskeletal system, a slug, it's really not doing much. You see it on the ground, and 2 hours later you come back and it's still there. Because he doesn't have a musculoskeletal system. We have a musculoskeletal system that allows us to move. And if there's something wrong functionally with the musculoskeletal system, it has to link back to being a movement dysfunction. So that's sort of what about 5 years ago it started to dawn on me as the probably the root cause or driving factor to create musculoskeletal related pain, regardless of whether it's spine pain, knee pain, hip pain, and shoulder pain, all those really common things that people suffer from. And therefore, if I was going to if I was going to do something about musculoskeletal pain, I then have to make people good at moving, and therefore I have to have a definition of movement. So to answer your question in brief, the points of performance that I look for and the points of performance that are associated with our program, they're really quite simple, but we want to in relation to back pain and spine region pain, because that's the part of the musculoskeletal system that I'm concerned with. But these principles will also apply to someone with hip pain and knee pain. I'm striving to train my patients on these 5 main points, which are hip-centric rotation. Okay, we have the ball and socket hip joint. I want patients to maintain a neutral spine position or be aware of their neutral spine position during movement. I want them to perform their movement with posterior kinetic chain powered musculature. So in contrast to the anterior chain or quad dominant movement, I want them to be posterior kinetic chain dominant. I want them to move with unloaded knee positions, and they're sort of interrelated, but unloaded knee positions, which really contradicts the workplace health and safety kneeling position. Keep a straight back and kneel. Bend at the knees and keep it straight back. That is incorrect, because that's a loaded knee position. And then the last of the 5 points is proficiency limited range of motion. Okay, so there's 5 points there. It's so simple. It's so simple.
Yeah, I'm not. It is simple for you.
Yeah.
I mean, I'm familiar with a number of those, except the last one, which is the proficiency point. So, can you explain that a bit more?
So let's presume that we've got a little old grandma who needs to get something out of the bottom drawer of her cabinet. And we're training her to move with hip-centric rotation, neutral spine awareness, posterior kinetic chain-driven movement, and unloaded knee positions. But that task of getting something out of the bottom drawer or putting something into the bottom rail of the dishwasher makes her move out of those good positions. So she breaches those 4 preceding points. Yeah. And therefore, if she tries to perform that task and breaches those 4 previous points, then she's not moving proficiently. Okay, so we then need to incorporate strategies to train her how to do that task.
Right, so to allow some flexibility and function.
Well, we would then train her to do that task so that she doesn't breach those 4 points of performance that preceded, right? Yeah. What happens though is as we just say, for instance, we said, okay, well, don't put the egg beater in the bottom drawer, put it in the 3rd drawer. So now she can get that object out of the 3rd drawer proficiently. As she does that for the ensuing several months, guess what happens? She could now put the object into the 4th drawer. Yeah. Because the movement proficiency at getting the task, at performing that task at a proficiency limited height builds capacity. Okay. Yeah. And then suddenly 3 months later, she can get something out of the bottom drawer proficiently. Yeah. And what does that equate to? That equates to an increase in functional capacity. Yeah. Okay. Because that's really the overarching principle. That's the overarching holy grail target of my rehabilitation of NeuroHab. We want to increase patients' functional capacity to exceed their functional demand. Yeah, that's it. Yeah. That's the underlying.
That makes sense.
10th law of thermodynamics, or whatever you want to call it. Yeah. If you've got a functional capacity that exceeds your functional demand, you're going to be happy. You're going to have a happy, robust, healthy musculoskeletal system. Yeah. But what happens to what do you hear from patients who are in pain? The first thing they say is, well, I don't mow the lawn anymore. Yeah. I don't.
So they limit their life further to pretend that they can still function, but actually
they don't play sport anymore. And you get all of the really sad stories like, I can't kick a footy with my 10-year-old son anymore because it hurts too much. So what these people are doing subconsciously is that they're maladapting as opposed to adapting.
Yes.
They're maladapting to their pain symptoms.
It's avoidance, fundamentally, similar to anxiety. You avoid the stimulus, and then you limit your life more and more, and in 5 years you're stuck in a room.
Yeah, exactly right. So they're restricting their functional demands, like shrinking, their world is shrinking, so that capacity meets demand.
Yeah.
And if capacity meets demand, they can get by until what happens then? Oh, I can't go to work. All right. And then there's no money coming in. And then there's a whole raft of psychological factors and depression, and their wife leaves them, and, they
start eating poorly.
They're destitute. And then, everything falls. And then this patient who has chronic pain is, of course, they're going to have mental health issues. And then we start to label them as a chronic pain sufferer because of the mental health issues. And no, if you say to them, well, what was your mental health like before you had to start restricting your demands in life? I was fine. I was working. I was happy. I was a truckie. I was a brickie. I was a labourer. I was an accountant. But now, do I have depression? Do I have anxiety? Am I on antidepressants? Of course I am. And all of the cognitive behavioural therapy, cognitive functional therapy, the psychology, that's all important, but it's missing the point. And I think a lot of the back pain therapeutic industry focus is on downstream phenomenon. So I sort of use this like domino train type of analogy where we're sort of targeting the 100th domino in the domino train when we're ignoring that first domino that fell over.
Yeah.
And if we continue to ignore that first domino and we keep trying to just patch up all these other downstream problems, then it's always going to fail.
Yeah.
It's always going to fail.
That's a good principle for medicine in general, really. Try and get as upstream as you can.
Yes.
So I want to just come back to a few of the points you've made. You talked about, and you sort of, how I interpret it as well, exercise in the sense of we've got this idea where you've talked about functional movement is a lifelong activity, where instead of, I think we've got some problems in the way we define a good or healthy exercise, inverted commas, or movement these days, where it's like, okay, I go to the gym for 30 minutes or 60 minutes to do my squats and my bench press, and then for the rest of the 23 and a half hours of the day, I'm slouching and I'm not moving much. And so there's a difference between fitness and health, so you can move in a very healthy way, which means now, as you say, your capacity is always going to be higher than your demand. And if anything, with age, you're probably just going to get better and better, or at least get, be pretty good. Whereas what some people do these days is they burn themselves out in their teens and 20s with high fitness, but poor quality, and moving poorly, that they eventually get injuries and then they start restrict their life. So we're sort of trying to go back, the way I interpret it is to moving well the whole time, and then you put on moving, often, and intensity and duration on top of that basis of moving well.
Yes. I think you're nailing it, Sam. It's a bit like what you're really describing is this. You're describing what I refer to as the concrete base foundation. So if you have a nice concrete slab to your home, you can decide what you want to build on top of that. You can build a straw hut on a concrete slab, or you can build the Taj Mahal. Okay, but the Taj Mahal gets built by long hours, working hard, just spending a lot of time building capacity, but it still needs that concrete slab foundation, which is movement proficiency.
Yeah.
If I choose to just be an accountant and just go to work every day and come home and do the housework and just mow the lawn on the weekend, and I've still got a concrete slab of movement proficiency as my foundation, I'm not going to be a mega super athlete, but I'm not going to be afflicted by musculoskeletal pain either. Yeah. Whereas if I want to win the Noosa Triathlon, I can work really, really hard and win the Noosa Triathlon. But if I but I can also be broken down. I can be broken down in pain. And I have many high-level athletes that come and see me with back pain, and they say that they were advised to increase their core strength. Now, that is ludicrous. That tells me that the paradigm that's being used is not focusing on skillful movement. Yeah. So what we then say to the high-level athlete is, okay, look, I know you're strong, I know you're fit, but you're not moving well, and that's what's driving your pain symptoms. Yeah. If I then turn around and teach that person to move well, he remains fit. It's not like he suddenly drops his fitness because he's now moving well, but he's doing those trivial daily life activities better.
Yes.
And if you think about your day, even if you're a high-level athlete and you were training 3 or 4 hours a day, not many people have time to train that long. Most people might spend an hour every second or third day at the most, right? So in your daily life, maybe 1 hour out of 17 or 1 hour out of 16 is spent training. What about the other 16 hours? Okay. Yeah. Now, if I make that athlete move well in those other 16, 17 hours, he suddenly eliminates his back pain symptoms, and he still maintains a high level of athletic performance. And so that's I think what you alluded to there is that you've got to have the foundation of movement first, which you then build upon. Yeah. And I think people get into trouble because you could be a 20-year-old bricklayer who's labouring and he's absolutely fine. He's working hard every day, but no one's told him how to properly move his spine according to those points of performance. So what happens to him as time goes on? He doesn't experience pain for the first 10 years of his career because he's got a high functional capacity. He's 20 years old.
And youth. He's
youthful. He's 20 years old. He's muscle bound, but so therefore his functional capacity exceeds the functional demands of that high labour work until he reaches 30, and that movement dysfunction that's been in his system for 10 years will cause capacity to decline. It can't not. Yeah. And when he hits the age of 30, I'm just being arbitrary, but say he hits the age of 30 and now he starts coming home with a sore back. Okay. And what does that do to movement? The moment you start to feel pain drives more movement dysfunction. More movement dysfunction drives more pain. And then now you're starting to ramp up this pain movement dysfunction cycle, which then what does that do to functional capacity? Drops it even more. And now the brickie goes, sugar, I can't do this work anymore. I'm going to go back to college and I'm going to learn an IT degree, because what that's doing is it's just dropping his functional demand. Yeah. Okay. So now he's okay again, right? So now he's working
as the lucky ones.
Yeah. So now he's working as an IT guy. Yeah. But the industry let him down and didn't say, hey, you could actually keep working as a brickie. All I need to do is give you the movement points of performance that creates that foundation again for you to build your functional capacity. You build your functional capacity, you can keep lifting bricks for the next 20 years. Yeah. Because lifting bricks well gives you an incredible functional capacity. It's like he's training 9 hours a day, 8 hours a day, 40 hours a week lifting bricks. Yeah. He should have a healthy, robust, pain-free spine. Okay? That's like me going to the gym 40 hours a week. If I go to the gym once a day for 1 hour, I'm going to be pretty powerful. If I go to the gym 40 hours a week, I should be incredible, and that's that. If you drive around a work site, you can see the workers who have good movement proficiency versus a worker who's still churning it out. But I can say that worker's probably got another 5 years of longevity in him, whereas that other worker's going to go to 65. Yeah, because I can see that one person is moving more proficiently than the other.
So there's a few other things that sort of come up there. I mean, that's the importance of getting these principles out early, really early. I mean, one of
Really
the
early.
things that I think is interesting about our modern culture is that at some point, I think most kids naturally move, and that's what's
They do.
so interesting watching.
They
I've got 2 kids, and one's only 8 months, and she just stood up, brought herself to stand today.
Yep.
And you see how they progress. They don't just go from blob to running. They figure it out for themselves. They roll, then they crawl, so they go from sort of 2-dimensional to all 4, and then they go to bipedal. And there's this progress of developmental movement, which I almost think,
developmental milestones.
that we need to actually, as adults, go back to. Like sometimes I get people to start rolling again and go on all 4s again. I was like, before we get you doing that stuff. But it's getting people early, because at some point we stopped moving, and in our life, stopped moving well, I should say. And I've done martial arts for a number of years, and one of the things I noticed just on self-reflection, that if you're going to punch hard or kick hard, there has to be a certain coordination and proper movement to do that. And just like you said with golf, if you get a good golf swing, that there's that feeling of connection that you're like, everything just was kind of good there. And it's the same if you throw a spear or if you throw a ball.
It's core to extremity.
That teaches you something. But now we've stopped moving. And I think we've forgotten how to move.
Absolutely.
And so I think the importance is to re-teach people.
I don't know whether it's been forgotten, but it's been forced upon us by modern society.
Yeah, that's what I mean. Yeah, it's like the lack of doing it means we've sort of just lost the habit of good movement. But it can be relearned.
Absolutely, it's difficult. Motor patterns are difficult. It's like sort of me teaching you to juggle 4 ping pong balls. It's not easy. And like you're referring back to your toddler, that your child has not done my NeuroHab program, okay? And he or she is expressing those 5 movement points of performance that I alluded to at the beginning naturally. It is programmed into their DNA.
Yeah, that's right.
They just do it naturally. But once they go to preschool, they go to primary, they ingrain in modern society. We sit on chairs for long periods. We're at school for 6 to 8 hours. We're watching TV. We're in cars. I refer to that as modern society's domestic cage. Okay, imagine putting a Bengal tiger inside a 2x2 meter cage. What do you think is going to happen to their musculoskeletal system? It's going to be there's going to be massive compromise, and human beings have created this modern society cage that we live in, and then wonder why we're not moving correctly anymore. Okay, and so all of those points of performance that I talked about, we start to not integrate hip-centric rotation. We start to incorporate lumbar-centric rotation. We start to load the knees. We start to lose that posterior kinetic chain activation of movement, which is all driven by our motor patterns being corrupted by modern society. It's almost unavoidable. And therefore that reflects very closely this massive increasing prevalence of back pain and musculoskeletal pain. World Health Organization, February this year, said musculoskeletal pain and back pain, out of those, all the MSK pains, was the leading cause of disability on the planet. Leading cause and when I read that, I said, right, this is completely and entirely preventable.
Yeah.
But the industry that's looking after these patients who are just becoming a massive part of our society is a little bit blind to the fact that the target of therapy is a functional target, not a structural or symptomatic target. Okay, but think about everything that a patient says to you when they come into your practice. Doc, I've got back pain. I need some time off work. I need some medication. Can I have some cortisone? The physio told me to do some core strengthening. I've taken up Pilates. I've had a massage. All of those therapies, every single one that I listed there, which is probably the top 5 that people do without even seeing you, right? They just go and do it, is a structure symptom-based therapy.
Yeah.
Okay, so core strengthening, structure. Cortisone injection, structure. Anti-inflammatories, it's targeting structure and the inflammatory mechanisms of pain. A massage, structure. Chiropractic adjustment, structure. and then a multitude of other symptom-based approaches. But not one of those patients has said, I think I need to fix the functional problem that's driving my pain. And I am trying to get the message out there that back pain is primarily a functional disease. It's a functional disease with secondary structural deficits that occur way downstream. And if we don't fix the functional problems in the very early stages of their presentation, so that first weekend warrior gardening episode, I need a day off work, that's when the message needs to be delivered to the patient and said, hey, your back pain is not simply because you worked hard. Your back pain is because you worked hard with poor skill. And if you get that patient really early at the age of 30 and they now understand movement points of performance or neurohab, they're going to work hard every weekend and they're going to be fine thereafter.
Exactly.
But if you don't get that message out to them, they're just going to take the next month off working on the weekend on the garden. They put that project on hold. Back pain settles down. Of course it does. That's just natural healing. And
it's your body being awesome.
That's your body being awesome because it just does that. You know, you get sunburn, your skin peels, and then the next weekend it's good again, right? But that patient whose natural healing processes kicked in may have gone and got a massage. They may have gone and had a physiotherapy session, right? And the fact that they got better 2 weeks later, they attribute that to the therapy that they received. And that therapy that they received did absolutely nothing to reverse the functional problem. It massaged the natural healing of the body. And therefore, when the patient gets another episode of back pain, a month later when he starts his weekend project up again, he has pain again because no one actually said, hey, this is how you move correctly. What's he going to do? He's going to go line up for another episode of another session of deep tissue release or something because he feels tight. And this goes on and on and on until the patient is in constant pain. Okay, and you know the stats about every episode of acute pain has about a 10% chance of persistence. So 90% of people, yes, they do get better. But every single time they have a flare up, they're skirting with the development of persistence. And once persistence kicks in and it's entrenched, their movement proficiency just deteriorates dramatically. Okay. And then
so one of the principles you've alluded to with the rehab process is local versus whole body. You know, so you mentioned core training, and as you say, that can have its place. But it's actually when we're looking at the whole body. So often people come in with knee pain or ankle pain or back pain, obviously, and we focus in on the back. Whereas we need to step back a little bit and look at their whole movement patterns that is underlying governing their life.
Absolutely. Well, core strengthening, it's such a favour. Like, it doesn't make any sense that strengthening up your core is going to protect you from back pain. I mean, you said it has its place. I say that, look, I'm happy that you've got a good core. Okay, so we're talking about obliques, we're talking about the diaphragm, the pelvic floor, the paraspinal stabilizers. That having a really strong, powerful core does not mandate movement proficiency.
No, absolutely not. They're not one and the same thing.
That's exactly right. Otherwise, otherwise we should tell every violinist to go and strengthen up their fingers. I could have super strong fingers. I can tell you that I'm not going to play a violin very well. Or I could say that there's no such thing as a really good 10-year-old golfer because they're just not very strong. But you look at a 10-year-old golfer who's got the movement skill and he drives the ball down the fairway straight as a die every time. You know, little Tiger Woods at the age of 6 wasn't very strong, but he had movement proficiency for the sport of golf. All right, so we want people to have the movement proficiency for the sport of life. And that doesn't require core strengthening. They've got to have adequate strength, of course. You've got to be able to pick up the golf club. But they don't need honing in and strengthening core. It does not help their back pain.
That makes sense. So when we're looking at this, when you're doing your program, because it's a neurohab program, so obviously there's what they say, the hardware and the software component. So there's the neurological. One thing I was explaining to a patient yesterday actually about there's the structure might be fine or may not be fine, but your coordination, innovation of those structures is what needs some training, some fine tuning, so you can actually move properly. Yeah. And that's, I assume, forms a big part of your program.
Yep. That's why we coined the term neurohab. Yeah. Because I'm not rehabilitating the muscle system. Okay, those type of programs are everywhere. Yeah. Every gym, every fitness first will have some muscle strength and conditioning program. Yeah. This is not a strength and conditioning program. This is a central nervous system motor pattern rehabilitation program. And that's what distinguishes it. That's what makes it specific, and that's what drives the changes in our patients. Yeah. From when they start the program to when they finish the program, they just move differently. And going hand in hand with that proficient movement is just a transformation in many aspects of their life, not just their musculoskeletal pain.
So let's talk about that. So let's talk about where do you start people when, let's say, the average person comes in, you can tell they've just got dysfunctional movement. Where do you start them? Obviously, you've got quite a detailed program, so we can't go through it all. But and especially for the listeners who are wondering, okay, well, whilst they're waiting to see how do I start them? Where do I start them?
Well, every patient that has chronic pain is complex. Okay, but complex, and this is why I get a little bit disappointed with our Department of Health and Ageing and the Choosing Wisely Australia stuff that says don't refer simple axial back pain to a spinal specialist. There is no such thing as simple chronic back pain, because anyone who is on medication or suffering pain continuously is complex.
It's either early or late.
Yeah,
not simple or complex.
Yeah. And some of the messages are, okay, so one of the real strong messages is don't send them to a spine surgeon, don't get imaging, or just reconsider imaging. And there's these associations that imaging is linked to a poor outcome. That just tells me that the person who's writing that guideline has got no idea about how to manage back pain. And I can see where they develop those ideas from, these associations, but it's misinterpretation of the data. And that message is getting put out there very powerfully by official recommendations. And saying that obtaining imaging is associated with increased back pain is like saying traffic lights cause car crashes, or it's not causation. It's just, how can an MRI cause back pain? Okay, it's not the MRI that causes, it's the interpretation of the MRI. So if you order an MRI, like so yourself, so say you order a CT scan or an X-ray or a lumbar or an MRI scan, that cannot cause a poorer outcome unless the interpretation of that imaging is poor and that an incorrect message is transferred to the patient.
So I guess that's the principle though, isn't it, too? Because there are people who misinterpret it and you're trying to avoid unnecessary surgery and cost of the scans as well.
So the target should not be then to say don't get an MRI. The target should be
to have a good interpreter.
Let's work out how to interpret the MRI. And if you can't interpret an MRI, don't order one. If you can't interpret a CT scan, don't order one. Send them to someone who can. And unfortunately, the number of people that are doing X-rays and CT scans and MRI scans are just looking at the report and not understanding what to say back to the patient. And that is highly dangerous. But I can tell you that the number of times that it probably happens on a monthly basis where an X-ray, a CT scan, and an MRI scan changes the management of a patient because I obtained imaging. Fractures, tumours, disc prolapses that are structural deficits that arise secondary to the primary functional deficits that need to be managed in combination with eliminating the functional deficit. That's why when I get a patient who has 5 years of back pain, I want to look at the structure. So I do want to have a look at the structure of the MRI, because that plays into the structure-function interrelationship.
Yeah. Management, of course.
Structure and function. Okay, so I want to be able to say to the patient, look, you've got a bit of disc degeneration, you've got some facet arthritis, you've got some bulging discs, but listen, that is not where we need to focus our attention on. We need to focus our attention on the functional deficits, which are creating inflammatory changes, nociceptive activation of those structural elements and creating pain and disability. If I eliminate the functional deficits in movement, then I can tell you that your facet joint won't be as inflamed, that your disc annulus won't be inflamed, that your muscles and tendonitis won't be inflamed. You won't need to have prolotherapy or injections, cortisone injections, because the inflammation will naturally heal when you start to move well. But it's very powerful for me to say to the patient, listen, your MRI scan is absolutely fine. It's got normal wear and tear changes, just like you've got grey hair and wrinkles on your face.
Yeah.
Okay, that's normal. Your spine is allowed to age as well. But if you go and stand in the sun at lunchtime for 2 hours, guess what? Your wrinkles will also become inflamed. And now you've got degeneration of the skin, which is also painful. So we want to just do the same thing with the musculoskeletal system. Is we want to transfer inflamed degeneration, convert it back to normal degeneration, because inflamed degeneration is painful.
So you can often use imaging, obviously, to rule out, you mentioned tumors, fractures, really nice things that will alter your management, but also as a reassurance tool in the sense of, okay, let's focus on where the money pot is. And the money pot will be on your movement, and because that's going to calm this down. We don't need to look much further at that.
Yeah,
and then the patients can go, oh, good, now I can move with a bit of, psychological freedom. There's not a sense of fear.
Powerful.
Yeah.
It's hugely powerful because but I've got to still make them move correctly. If I just tell them, hey, everything's cool,
you're fine,
just keep doing what you're doing as you have been for the last 10 years, they're screwed.
Yeah.
But if I tell them that their spine is okay, it's normal, it's a normal 60-year-old spine, start moving well and it won't be painful.
Yeah, like how you said, inflammation will heal when you move well.
Let's use the word degeneration versus degeneritis, or spondylosis versus spondylitis.
Yeah.
Okay, one is normal, one is pain-free, one is
painful,
symptomatic and painful. Yeah.
So what you would have had you've been doing this for a while now. So what are some outcomes you've seen? Because it's nice to bust some myths, which I see all the time, but either chronic pain is forever, or that disc herniations can't improve or can't become asymptomatic. So what are some of the outcomes you see musculoskeletal? But also, I would imagine you've had a fantastic flow-on effects, because my experience in movement has been when people start moving, they go, oh, is this what good health feels like?
Yeah.
They say, I want more of it. So they start eating well and they start exercising more and they start, all those other things. Yeah. So you must have seen both primary impressive outcomes, I'm going to assume, and impressive secondary outcomes.
Incredible. It's life transforming, because movement is one of the 4 fundamental pillars of health. Okay, so I talk about 4 pillars of health, and they are, of course, nutrition. Defined good nutrition, which keeps insulin resistance at bay. So I don't care how you do it, whether you do it eating carbs or not eating carbs or eating fat or whatever. As long as you maintain insulin sensitivity, metabolically you're going to be pretty healthy.
Yep.
It's a unifying disease of metabolic health is insulin sensitivity. So that's part of our program. Movement proficiency, defined movement proficiency. Not just move well or just go and exercise, because that's useless. That doesn't help anybody. Adequate sleep, quality sleep, and control of stress.
Yeah.
Okay, so there's the 4 pillars. They're like the 4 wheels of your car. You check off those 4 things and everything just falls into place. Your relationships fall into place, your mental health falls into place, your economics fall into place, your productivity falls into place. So a lot of our patients have significant deficits in all of those 4 pillars of health, we start unraveling those problems, they just transform. They become absolute. Like a lot of times, patients will be sitting in that interview chair there, crying on opioids in pain, and at the end of the program, they just don't want to leave.
Yeah,
they don't want to leave, and
they're crying for another reason.
That's right. Yeah. I opened up a Christmas card today, saying that exact same thing. Thank you for changing my life.
Yeah.
And it's not with surgery.
No.
Okay. Surgery is required, but surgery does not fix back pain. Okay.
But often, if you do this well, it's not required. I would think. That's obviously, when they get to your level, you've got a selection bias because you're getting the most difficult of the difficult.
Yeah.
But for us in particular, I've had cases where people have had chronic pain and or pre or post surgery. Yeah. Gone through a program with me, which is nowhere near as rigorous as you, and a few of my select physios and EPs in my area.
Yeah.
And then they're off their opioids and they're pain free and they want to go back to study and they feel and it's an exceptionally rewarding part of the job.
Yeah.
But also, of course, primarily for them to give them their life back.
Yeah. Yeah. I mean, have you read my article that in Surgical News? You probably have, but it's outside and it's titled "There is no such thing as back pain surgery, but don't refuse to fuse." Because this is the biggest mistake that surgeons make, is that they think that someone's got a structural problem, and therefore if I fix that structural problem with my surgery, a fusion, a laminectomy, discectomy, stabilisation, that they've fixed the problem. And the patient may or may not actually feel better after that surgery. But as we just alluded to, back pain is a functional problem. How can surgery fix a functional problem? Surgery is 100% a structural fix. Okay, so it's almost a bit like saying, how can a car mechanic fix a car that's continuously being driven by a drunk person? They don't really. They might.
Yeah.
Get the wheel alignment back up.
Get the airbag going again.
Yes, exactly right. But then that functionally disabled driver gets behind the wheel again and is in another car crash. And an example of a patient who had a fusion, L4-5 fusion, for terrible pain, because she obviously had movement dysfunction. She, over years, started to break down her lumbar L4-5 disc, went and saw another surgeon, had the surgery. A year later, is still in agony, still on endone, somehow hears about us, comes and sees me. We put her x-rays up on the board because, of course, I want to see what the surgery looked like. And she's just sitting there bawling her eyes out going, I went back. I said, have you been back to your original surgeon? And she's saying, yeah, I went back to see the original doctor, the surgeon, and he just gave me the thumbs up. He said, everything is fantastic. Why am I still on endone, doc? Okay. And so there's an example of a doctor thinking that surgery fixes back pain. Did she need that surgery? Of course she did. She had a structurally broken down disc. She needed the surgery, but the surgery doesn't fix back pain. It's a structural fix. Back pain is a functional disorder. And so once I explained to her, hey, look, your surgeon's done a marvellous job. Hats off to him. I was very impressed. Beautiful operation. Mine looked like that too. But what I don't
structurally, it's great. He's right. But he's missing this big part.
Huge.
Yeah.
Okay. What I don't leave out, and what I got her doing, was fixing the functional fix. Yeah. So she completed the NeuroHab program. 8 weeks later, she goes, this is incredible. And I can tell you, last weekend I just went and ran up Mount Cootha with her.
Yeah, fantastic.
Okay. So and she's now going, I want to become a movement therapist. I want to,
That's a common story, isn't it? When you start hearing people go, okay, I want other people to experience what I've experienced.
And her diet's changed.
Yeah.
And it's just like they sort of say that their whole, you've almost changed their whole life, their whole family interaction.
As you say, the flow-on effects as well to their family. And
that's what makes it so rewarding. It's not an economic model that we do this for. It's an absolute necessity as part of my neurosurgical practice because if I'm operating on people, I need to fix the functional elements as well. I don't want to rely on the physical therapy industry. In fact, I haven't referred a patient to a physical therapist in the last 3 years because I just cannot rely on the physical therapy industry delivering movement therapy. Every single patient that I've seen has a letter coming back from their general practitioner saying, so-and-so has done 6 months of this, this, and this, and this, and they're still in pain. Okay.
Do you think that's changing though? Do you think because it would seem to me that there's more and more EPs especially, but and other specialties, physios and whatnot, who seem to be thinking and talking a lot more about this area now. In my conversations,
they are thinking about exercise and they are thinking about fitness.
But I mean movement. I don't think there's more people thinking about the whole movement patterns. The problem I think we have is there's no real set structure to the teaching and to the application of it. So everyone, you know, Sam's got his style and John's got his style and Jane's got her style, and then it makes it very hard if there's no standardized approach to this, to know what has failed technically. Yeah. So that person's failed, but we don't really
reverse engineer the problem. If it was changing, Sam, we would be seeing improvement in numbers. And if you look at Lancet data, the numbers are getting worse.
They're not getting better.
They're getting worse, and also the guidelines are getting worse. The guidelines are getting worse. So the people who are putting out the Australia's leading researchers are actually doing the opposite. I don't know whether you follow some of the publications out of Curtin University. I don't want to mention names, but they are actually saying the exact opposite. They are saying, don't worry, it's okay to round your back. Okay, so they're almost I can show you some links later, but these are Australia's leading researchers that are saying to people, there's no such thing as bad movement, just move. So they're not really, they've got no concept of defining movement proficiency. And you mentioned earlier that you love doing kettlebells, right? You try to do kettlebells. You try to do 20 kettlebells with a rounded back.
Yeah, I know.
I can promise you.
Just sitting here in this chair's done it, kill me.
Yeah, because we're not moving.
Well, I'm twisted and I'm sitting in this one position.
Yeah. Well, maybe. But what it tells me is that these lab coat wearers have no idea how to swing a kettlebell.
Yeah.
They have no idea how to do a clean and jerk or an Olympic snatch. Because if you understand functional movement, and believe it or not, Olympic weightlifting is the epitome of functional movement. Okay, you look at it: hip-centric rotation, posterior chain, neutral spine position.
Do it well. It's beautiful.
Powerful core to extremity movement. Yeah. If you understand that, you won't go out there telling people to round their back when they're lifting their suitcase. It's just insane. Yeah. And I'm actually currently working with Professor Stuart McGill, Kelly Starrett, Amy West. These are
mobility ward.
Yep, these guys know movement, and we're writing a opinion piece that'll hopefully get published in a reputable spine journal.
Great. I've been following his work for quite a while.
And Professor Stuart McGill. Okay? These
he's wonderful.
These guys are biomechanists, right? And or he's a PhD biomechanist, and it's physics, it's mathematics. If you round your back, you're going to destroy the matrix of connective tissue that is part of the integrity of the spine. And if you add on top of that repeated loading, it's going to happen even quicker.
Yeah.
Okay. The only some of the things that they say are that to support their argument is that, well, I just rounded my back and tied my shoelace and I'm okay. Yeah, but that's like saying I just had one cigarette and I don't have lung cancer yet.
Yeah, well, I was in the sun for 5 minutes. I didn't get
ridiculous. It's insanity. Do it over and over and over and over again, and yes, you're going to get a disc prolapse too. Yeah. And I just cannot understand how these obviously very smart people, bloody professorships before their name and stuff like that, think that that's a message that they can put out to the Australian public. And I'm close to writing to the APA about it, because these guys are reputable researchers that have no idea about biomechanics.
Do you think it's, you mentioned the word researcher, so because a significant amount of my own personal insight that then flows into my clinical and professional insight and practice is my experience doing it myself.
Yep.
So having, like I said, trained and doing kettlebells myself and doing Grey Cooks training and that sort of stuff.
Yep.
Just doing it myself, going through the movements myself, going, now I understand
properly,
why this happens. And I just did this a little bit differently, and now I understand this. And then you go and see your patients, you go, okay, take your shoes off, I need to look at your feet now, and I need to do this, and can you just try and do a squat and see how that goes? And you start to, so it may be the lack of people's experience, personal experience, that may also be impacting this.
100%, 100%. For myself, if I wasn't a spinal surgeon, if I wasn't interested in functional movement, and if I didn't start doing Olympic weightlifting, I would not have put the jigsaw puzzle pieces together. And it's just serendipitous that I happen to be able to become aware of functional movement proficiency and define movement proficiency for my patients that has allowed me to put this program together. Otherwise I wouldn't have. And I look back at my notes from say I sometimes see a patient that I might have seen say 10 years ago or early on, and I've still got my records. I still that they come back, they may have had a discectomy 6 or 7 years ago before movement therapy, before neurohab, and they've come back with another prolapse, or they've come back with progressive back pain. And I say, I'm sorry, I did an operation for you, but I didn't rehabilitate you correctly. It's no wonder now that you're back with more pain, or you're back with another disc prolapse, because I didn't complete that circle of care. I didn't eliminate the actual cause of your disc prolapse. Okay, and I just fixed the symptom. The disc prolapse is the symptom of the movement dysfunction. So there really needs to be a chapter in the textbook saying entitled "Movement Dysfunction causes back pain." What's the most common reference for back pain? Non-specific low back pain. There'll be a research article in this month's Spine Journal called "Non-Specific Low Back Pain." What does that tell you? It tells you that our leading researchers, there's a couple of them that I've had conversations with, that are basically copping out. If you title a disease with what is actually a symptom, you've given up. You've gone shrugging your shoulders. I don't know what causes back pain. Let's just call it non-specific. Let's just call it non-specific. You've got shortness of breath syndrome. How likely are you to succeed at eliminating shortness of breath syndrome when you don't say, hang on, no, you've got asthma. Okay, let's fix your asthma. Let's get to the root cause of your asthma. Now your shortness of breath goes. But if I just say, no, you've got back pain, and I use that term interchangeably as the diagnosis instead of the term movement dysfunction as a diagnosis, I'm just going to keep treating symptoms. Whereas if I say, hey, Sam, you've got movement dysfunction, that's causing you back pain. And now I go and treat movement dysfunction, which means I can't go to a therapist and lay down on a couch because that's anti-movement. And I go and treat movement dysfunction effectively. And you've seen our coaches how difficult it is to train movement proficiency. You can't just do that without some skill sets. Then I've eliminated the disease, and then the back pain symptoms disappear. And that's probably one of the other problems is educating our physical therapists about movement proficiency and then how to deliver it. I said to you,
and primary care and all other. I mean, because so that comes back to my sort of last two questions. One, how can obviously podcasts like this and other things, how can we get this message out so that it becomes part of the system, as it were? And then the other thing is, what are some practical points as listeners who are clinicians can start to take away from this and what they can start doing with their patients? Because if they can't get to your service for whatever reason, surely there are other things that can be done. So I have certain resources that I encourage patients to look and read and watch, and then there's certain I know certain EPs and physios who I've connected with directly who work in this field a little bit more. But what are some, so the big picture and the local picture?
Well, the local picture is that there are, especially on the Sunshine Coast, there's 2 functional movement training centres on the Sunshine Coast. I'm always trying to help other physical therapists who are interested. And I'll say to a patient who's, we have a service in Bundaberg as well, but say they're from Gympie or Mackay or somebody, 2 hours, 3 hours, look, just go and see your local therapist. Please ask them to videotape the treatment with you, upload it to a Dropbox or whatever, and email it to us. My coaches are more than keen to look at the therapy that's being delivered to a patient and look at the movement training. And, very, very rarely will a physiotherapist or an exercise physiologist actually send us something. But if they do, and we can then look at that video and say, look, you're not quite hitting those movements. This is how we would cue, or this is how we would strategize or scale the movement progression to achieve the desired objective. So we're more than willing to help patients in that regard, but it's going to take a bit of a generational gap, like acceptance. And I think there's a little bit of an air of arrogance in the industry that probably doesn't want to be educated through a more, gym junkie type of approach, where that's what's the perception of movement therapy is, that it's coming out of a Olympic weightlifting background or strength and conditioning background. They don't want to be educated by Cougar's weightlifting exercise strength and conditioning coach, because he doesn't have the letters after his name. But his awareness of movement proficiency is fantastic,
Yeah.
But there's a generational gap, and that's certainly in our targets, is to try to get into educating the universities, physiotherapy courses, things like that, developing our own courses, working with people like Stuart McGill. He does courses all over the world, and we get a lot of interest, but it's about time. And
what about for people who are not that local to you? I mean, do you have resources that people can at least, if people have heard this and they go, wow, this sounds awesome, I want to learn more. Yeah. So what are some resources you would recommend? I mean, we've mentioned Kelly Starrett. I've mentioned Greg Cook. You mentioned Stuart McGill. So they're probably some of the 3 big names in this field that they can start reading their stuff. They've got good books and, YouTube resources and things like that.
Yeah. Oh, look, in terms of our own stuff, there's Facebook, and that's where I put a lot of our patient stories up. Functional Movement Training Centre on Facebook is really good, and obviously the website, fmtc.com.au, I think, www.fmtc.
And you have some resources on the web?
Yep. Lots of YouTube links. But that book's pretty good, the movement book.
Yep.
So that's the Grey Cook. Grey Cook. Yep.
And I think Stuart McGill co-wrote
Stuart McGill, and that's the beginning of movement assessment.
Yeah.
It doesn't really go into, okay, you've got real deficits here. Yeah. How do we fix it? Correct, it's sort of like, it's a little bit like learning the alphabet, but not learning how to put sentences together. Yeah. You can know the alphabet, but someone's got to then teach you how to write an essay.
But it takes, I think, I don't see my job. My job, I feel, is more the assessor to go, okay, now I can see where the issues are. Now I'm going to push you in the right direction. Yeah. I would never consider myself trained enough to run a movement program. No. That would be ridiculous. Yeah. So it's more that I want to be aware of the principles and coordinate the care. Yeah. And pick, okay, that's where the issue is and we need to work on that area, but then get someone who's really dedicated their life to it to work on it.
Yeah. Well, when I retire from actually performing surgery, I am optimistic that functional movement training centres are going to be the reflex action for a general practitioner who has a patient with back pain.
That'd be good.
Not off to the Pilates studio.
Yeah.
In fact, Pilates is probably going to be struck off
Or I think it has.
Insurance policies, because there's no evidence.
Yeah.
There's no evidence that it actually helps back pain.
Yeah.
There's nothing wrong with doing it, but if you knock on a Pilates studio door and say, I've got back pain, and six months later you're going to leave that Pilates studio with back pain, you'll have a stronger core, but you're still going to have back pain.
Yeah.
And so it's not a clinical program for fixing back pain.
Yeah.
There's nothing wrong with Pilates. Do it if you like it, if you like the social scene. But if you're a back pain sufferer, it ain't going to help.
Yeah.
You know? And that's what people do it for, is that, hang on, I've got back pain. That's why I started.
Yeah. Yeah. I mean, like you, I sort of envision one day I'd love to have the GP clinic on the side within a functional movement and a nutrition kitchen setting, and with a little meditation studio on the side. That'd be my goal, but one day we'll get there.
You're hitting those fundamental health pillars on the head, and that's really foundational preventative medicine. But it's just so simple. It's just so simple. You know, eating well.
Simple but surprisingly complex at the same time.
Yeah.
Like you said, partly because we've sort of forgotten a bit. Like the food might be, I think, is more complicated than it needs to be.
Mm-hmm.
But I think the movement still now needs some external teaching.
Yeah.
I don't think people can self-teach themselves good movement.
It's highly skillful.
Yeah.
But you mentioned eating there. Being healthy shouldn't be complex.
No.
Like if you turn back time to 500 years ago, there was no Google, there were no computers, and availability to access research was minimal. And how did we become the dominant species on the planet if being healthy was complicated?
Yeah.
You know, it's just we just ate something with eyes and tails, and that got us through. Nowadays, you Google what's healthy, and you've got to be bombarded with the health star rating, low GI, the nutrition
more
panels.
Complex than it needs to be, for sure.
And it's just economical. It's commercially vested. They're purposely, the industry is purposely muddying the waters, and there really isn't much research dollars that are going to go into bacon and eggs.
Hopefully there's some more research that will go into functional movement. As it seems like there is more and more, and hopefully more and more.
Yeah. Absolutely.
All right. Well, thank you so much for your time, David. That was fantastic.
I don't know how long have we been going?
A while. Yeah. But this is about my average length, so it's all good. So thank you so much for your time, and I love your work, and I hope to see it bigger and brighter and go on stronger and stronger.
Very enjoyable. Sam, great GP.